Zelenko. I'll take that as a great honor. Doctor, welcome to our show, and we'd love to just hear what you're talking about. We know you're writing a paper discussing your results, and you have the floor, sir. Please tell us what's going on.
So thank you so much, and God bless you. Thank you for having me. So I'll just give you the background. I'm a doctor for 35,000 people who live within a 1 square mile. And I knew that when the virus will hit this community, it will spread because of the population density. And basically the whole focus of the world up to this point has been to build more respirators. There's been zero emphasis on how to have a clinical intervention, pre-hospital, in the primary care office that would slow down, prevent, arrest development of catastrophic pulmonary complications. So every doctor around the world at this point has been telling patients that come into their office that have the infection, go home, pray, drink fluids, take Tylenol, and if and when you develop pulmonary complications, go to the hospital, you get intubated, and then you have a 50% chance or more of dying. That's the treatment model up to this point. Now, nowhere in medicine ever do we have an approach where we let a fire get out of control before we try to put it out. So, for example, someone has the influenza virus, they come into the doctor's office within 48 hours, they're given Tamiflu. Someone has strep throat, they come into the doctor's office, get antibiotics before they develop rheumatic heart disease and need open heart surgery. Someone has an infection on their foot, for example. They don't wait until they become septic and half dead before we treat it. Someone who has appendicitis, we don't wait for it to rupture before we treat it, except when it comes to COVID-19. When it comes to COVID-19, we wait. We allow a subset of patients who fall into the high-risk category that have a 5 to 10% chance of dying to develop these terrible infections. The government tells you not to treat them. They tie our hands. The patient ends up in the hospital, half dead, and then they do studies that came out recently, and all these studies have one thing in common, that they are done on the sickest of the sickest patients on ventilators. They cherry-pick these patients who have a mortality rate above 50%, and then they come to the conclusion that these patients, the medicines didn't help. And I agree, they don't help at that point. I could have told them, could have saved them a lot of money. So the key here, and the nefarious, evil, terrible lie that's being propagated, is that they take data or results that apply to a very narrow spectrum of patients, and then they make a logical fallacy and generalize it so that they disparage this medication so that to say it doesn't work. You cannot make that conclusion from flawed studies that are designed to fail. So let me tell you my data, okay? I saw 1,450 patients diagnosed with COVID-19. Out of those, I divided them into 2 groups, high risk and low risk. Low risk I did not treat because they're going to get better without any intervention. High risk, defined as over the age of 60 with symptoms, under the age of 60 with symptoms but have chronic medical problems like cancer, diabetes, high blood pressure, things like that, or anyone that just really looks sick in my office, toxic, difficult breathing. I group them into the high-risk category because they have a 5% chance of dying probably in this country. And I treated those patients, 405 patients that fell into that category, out of almost 1,500 patients. So it's a minority. It's not a majority. But they are the high-risk patients. If you look in the hospitals, these are the patients that are dying. And I initiated treatment, and here's the key. I initiated treatment based on clinical suspicion, even without confirmatory testing. I did the testing, if I had the tests, but I did not delay treatment for 72 hours because it took 3 days to get the results. And those are the crucial 72 hours that if we intervene early, we can reduce the viral load in such a way that the compromised person's immune system could actually clear the infection without the development of these terrible acute respiratory distress syndrome or pneumonias. Now, my data shows like this, the following, that out of those 405, I had 2 patients die, 4 patients on the respirator. Now they're off the respirator, and 5 or 6, I forget, admitted in the hospital with pneumonia, so IV antibiotics, and most of them are home already. Statistically, you would have expected 20 dead, and a multiple of that, probably around 30 or 40 on a respirator. So that was a significant order of magnitude better outcome than was statistically being reported. I made a YouTube video addressed to the president, said that, look, I found something important. Next day, Mark Meadows called me. He wanted to know what I was doing. I told him. He said, but at that point, I only had a very few number of patients. So obviously, you couldn't make generalized conclusions from that yet. And then he told me to keep in touch. I had his cell number and email, and I periodically, every few days, gave him updates. Then Sean Hannity somehow got to me, and he read my written protocol on air. That night, he presented it to the vice president. Then 2 days later, the Mayor Giuliani called me, and I did a 45-minute podcast since then with him. And since then, the world has exploded. I've been literally consulted by governments because this is a world war, you see. 182 countries are fighting the same enemy, and no one really has an answer. Now, the answer that I developed costs between $12 and $20 per person. And it's oral, it's pills. And these are old drugs. Azithromycin is the most common antibiotic in America. Hydroxychloroquine is 60 or 70 years old, used for malaria prophylaxis, and rheumatological diseases. I have so much experience with this drug. It's used for rheumatoid arthritis, lupus. Never had any problems. I spoke to 3 electrophysiologists. These are cardiologists specializing in the electrical system of the heart, the rhythms. And I said, well, because everyone says side effects, they're dangerous. So I said to them, well, let's quantify that. Let's really see how dangerous they are. So amongst these 3 electrophysiologists, they had 100 years of clinical experience. I said to them, did you ever see a complication from hydroxychloroquine? No. I said, can you quantify the risk? They said, probably 1 in 1,000. I don't know. So think about it this way. If you have 1,000 patients at a high risk, and I give this medication to 1,000 patients, maybe 1, theoretically, may have a negative outcome. Maybe. But 100 will be saved. So everything in life is a risk versus benefit analysis. You get into the car, you take a risk of dying, but you go to work because you need to make money. So every second of your life, you're making risk versus benefit. And medicine is no different. So I'm not saying we should treat everyone. Yeah, go ahead.
Doctor, could I ask you a real quick question? Because I know a lot of our viewers are questioning it. Do you see any benefit to the zinc along with the hydroxychloroquine and azithromycin?
I was the advocate that started this. Let me explain to you how it works. It's not magic, okay? If you had the scientific basis for what's going on, you would understand, and it will answer all your questions. So, is that okay? Can I explain to you how it works?
Absolutely. Yeah, by the way, Doctor, we also want you, just keep going, but we would like to, can you stay over for the next segment, too, after we break for a commercial break?
I'll stay as long as you want.
Okay, fine. Keep rolling.
Thank you, Doctor.
So zinc is well known to inhibit viral replication, which basically means the virus can't grow or reproduce. The way it does that is that it inhibits an enzyme that's within the cell called, well, it doesn't matter. It's called replicase. What it does, that enzyme is essential for the virus to make copies of its genetic material. The problem with zinc, it doesn't get into the cell. It's like oil and water. They don't mix. So zinc is a positive charged ion. The cell membrane is like cholesterol, basically oil. So the zinc cannot cross into the cell. And that's a problem because that's where the virus is. So what hydroxychloroquine does, are you ready? It opens the door and lets the zinc in. That's it. In other words, you have a kill weapon, but it can't get to the battlefield. Hydroxychloroquine opens the door, delivers the weapon to the battlefield, you have good results. And the antibiotic is there, azithromycin, because we know that when lungs are damaged by infection, they become vulnerable, susceptible to bacterial pneumonias. So the antibiotic is there as a guard, so to speak, by the front door. If the bacteria wants to get in, it kills it before it takes hold. That's it.
Wow.
And
can I just go through some? Yeah, but hey, let's go. I want to ask you just quick questions. I'll tell you what, we're going to take a commercial break. Let's do this. Doctor, if you can stay. Dr. Vladimir Zelenko, the hero of the Battle of New Rochelle in this global war against the president